Dr. Burish received his MD PhD in the Vanderbilt Medical Scientist Training Program. He completed his neurology residency at the University of California at San Francisco, and then he went on to complete his fellowship in interventional pain management in the Department of Anesthesiology at UCSF, and later obtained a headache certification as an attending through the UCNS practice track. Dr. Burish's cluster headache work surrounds epidemiology as well as basic science circadian mechanisms. His clinic is part of the American Registry for Migraine Research, and he will speak to us today on post-stroke pain and headaches.
So thank you, Robin, and thank you everyone for having me. I'm honored because I think we're closing out the lectures today. So today I'm presenting topics in headache and pain that I think vascular neurologists would find useful. For financial disclosures, just to let you know, I do get some funding from a local headache foundation called the Will Irwin Headache Research Foundation, but I'm not a consultant or speaker for anything I'm going to be talking about today. We're going to be talking about things like chronic post-stroke pain and RCVS. So as you might guess, we're going to be talking about a lot of off-label things. So for lecture objectives today, I'm going to discuss three topics that I think this audience would find interesting. The first is the treatment of post-stroke pain. The second is RCVS, or reversible cerebral vasoconstriction syndrome, as sort of that is essentially co-managed by headache neurologists and vascular and interventional neurologists. And the third is discuss the 7 new migraine medications that have come out on the market for in the last 2 years. So in doing this last part, I want to focus on 2 things. The reason I think it's important is because first, these medications are vasoactive. So if you take care of a stroke patient that also has migraines, you'll likely be involved in the decision-making process of whether the patient should continue to take these medicines or they should stop them. And then second, these medicines have all come out in the last 2 years, some of them in the last 2 months, and we don't know everything about them. It's very possible that somebody in this audience will be the first one that recognizes a vascular problem in clinical practice. So it's helpful to know what these medications are. So let's first start with chronic post-stroke pain. So as far as defining it, there's no pathognomonic features to it. You guys have heard of, I'm not sure I'll pronounce it right, but Dejerine-Roussy thalamic syndrome, but that's only one type of post-stroke pain. Here are our definition, is the kind of more vague definition that people have accepted. So it occurs after a stroke. It corresponds to the location of the lesion. It's characterized by some sort of neuropathic pain as well as some sort of sensory abnormality. So neuropathic, obviously burning, itching type of pain, electric type of pain, and then sensory can be numbness, but can also be paresthesias or something else. And then you've ruled out other causes. Not the most exquisite or eloquent definition, but this is kind of the definition we have. This was a kind of an epidemiologic thing. So the prevalence is around 5 to 10% of patients. So I compiled this table from 2 review articles and reordered it from top to bottom by the number of patients in the study. As you can see, patients were collected from a variety of sources: stroke registries, inpatient, outpatient, rehab facilities, and they followed them for at least 6 months. And the prevalence varies somewhere between 1 and 30%, but most follow kind of the 5 to 10% range. So post-stroke pain really is not a rare phenomenon, and we do see it in a decent amount of patients that are discharged from the hospital every month. There are some locations that have a higher risk for getting post-stroke pain, and so there were some studies here that look specifically at 2 locations that are particularly high risk. One is the lateral medullary infarct or Wallenberg syndrome, and then the other is lesions in the ventroposterior part of the thalamus. So if you look at these studies, which just focused on these high-risk areas, they do have a little bit of a higher prevalence. For features of post-stroke pain, the cause can be hemorrhagic or an ischemic stroke. The time course, it typically starts within months and lasts for a long time, although there have been some documented cases they start as soon as a few days afterwards, other documented cases that started years afterwards. The intensity is typically a moderate pain, and the location is highly variable, as small as the hand to as large as the hemi-body. Again, it's a neuropathic pain. Sometimes it resembles more of a peripheral neuropathy type of pain, kind of a constant burning, freezing type of pain. It can also resemble sometimes a more of a radiculopathy or sciatica type of pain, where it's a shooting intermittent pain. Kind of typical aggravating factors that we see with some pain syndromes, things like stress or temperature. It's better with rest or distraction, and then again associated with some sort of sensory abnormality in the painful area. For mechanisms, these are all just different figures for basically kind of getting at the chronic post-stroke pain. All of them are essentially variations of some sort of disruption of the spinothalamic tract, or the STT, as it connects to the thalamus. So kind of figures part A, B, and C propose pathways that lead to increased activity or disinhibition of the medial thalamus. The blue, again, is decreased activity. The red is increased activity. Figures D, which is kind of the most simple one, and figure E, they actually propose changes in the firing rates between areas in the thalamus or cortex. So these are our kind of thoughts on the mechanism for chronic post-stroke pain. I'll admit that my area of expertise is not thalamic pain connectivity, so going into detail about these is unfortunately beyond the scope of this talk, but this gives you a general idea that chronic post-stroke pain may be a spinothalamic mediated mechanism. For treatment of post-stroke pain, I thought this was a nice table that reviews some of the more important studies for treatment of post-stroke pain. A few things that I kind of want to highlight on here. Number one, all of the numbers are pretty small as far as the studies go. Some of these are negative studies, so carbamazepine, ketamine, morphine, and naloxone were actually negative studies. The most effective, kind of looking over this, kind of looking at number needed to treat, is amitriptyline. For amitriptyline in the study, the plasma levels of amitriptyline actually corresponded with pain relief. So I don't usually get amitriptyline levels for other pain syndromes, but it may be worth looking into for chronic post-stroke pain if the patient's not getting relief. There is one here, lamotrigine. Despite this positive finding, there was a more recent study that kind of called this into question, whether it's actually helpful or not. And something that came out after this that's not listed on here is levetiracetam, which was tried about 6 or 7 years ago in about 33 patients. It was not helpful. So if you think that maybe the updated data here is negative, then you're looking at amitriptyline, pregabalin, and maybe lidocaine or propofol infusions. There are some neuromodulation strategies that have been studied. Probably the one that has the most data for it is motor cortex stimulation, but all of these have been studied to some extent. Just the data is just a little less clear. Neuromodulation in pain, I think just like a lot of other places, is still an emerging field, and so these things haven't been studied as detailed as some of the medications. Amitriptyline and pregabalin again seem to be the most helpful based on the clinical studies. And amitriptyline and pregabalin, as you all know, are used for a variety of neuropathic pain syndromes. So here's a figure showing you how its effectiveness in chronic post-stroke pain compares to other pain syndromes. For the trainees in the audience, this is a forest plot, which is a simplified way to look at clinical trial data. So just a real brief explanation of forest plots. The squares are the sample size. The lines are going across the squares is the 95% confidence interval. And then this diamond at the bottom is the kind of meta-analysis of the summary data from putting all the ones above it together. This solid line over here is kind of the 0 mark. To the right of this is essentially benefit. To the left of the line means it's actually harmful. If the confidence interval at that line crosses the solid line, it generally means that it's a non-significant study. So just these were taken from a very large neuropathic systematic review. I'm just going to kind of color them so it's a little bit easier to say, but this group down here by Finnerup is a well-known kind of neuropathic research group. But if you look at stroke pain compared to other things like spinal cord injury, peripheral neuropathy, shingles, sciatica, those types of things, it's as good as as it, it is for peripheral neuropathy, for example. So if you think it works in peripheral neuropathy, it's something that's probably worth trying for stroke as well. Just to compare for pregabalin, kind of same thing here. It may not be as effective, again, because it crosses this solid line here, compared to how effective it might be for things like peripheral neuropathy or shingles. But I think it's something that's still worth trying. So typically for chronic post-stroke pain, the first line thing has been amitriptyline, just because of the data, even though the clinical trial was only 15 patients. The second line are some sort of gabapentinoid, pregabalin, gabapentin. People have also proposed a second line, the SNRIs like duloxetine or venlafaxine. And the third line things would be those things that have, maybe they work, maybe they don't, like lamotrigine, where they have kind of debatable success in the clinical trials or in the studies, and maybe carbamazepine. There's a small study that might have been helpful. Things that are kind of after the third line, people have talked about maybe some of the NMDA receptor blockers, ketamine, memantine, amantadine, those types of medications. But it's really kind of amitriptyline and then everything else for chronic post-stroke pain. So let me move on and talk about RCVS. Again, these patients are often co-managed by headache specialists and vascular interventional neurologists. Actually, last year I co-managed an RCVS patient with one of your board directors, Sunil Sheth, who gave one of yesterday's talks, and I know is here. The patient presented to my headache clinic with recurrent thunderclap headaches, which is fairly typical, and I sent her to Dr. Sheth for an angiogram, and he made the diagnosis. I have to say it was a pretty subtle finding on the angiogram, so Sunil, I know you're listening. Thanks for helping out on that one. So just a summary for our CVS. I'm going to summarize it here at the beginning, but then go over all this in detail because repetition is the key to adult learning. So the clinical features of this, it's recurrent thunderclap headaches over a few weeks. They can occur spontaneously, or they can be triggered some way. It's often some sort of sympathomimetic medication or sympathomimetic condition like pheochromocytoma. It can also occur with Valsalva, coughing, or sex. And with sex, it's usually as you're approaching orgasm or with orgasm. The cause is unknown, some sort of cerebrovascular tone issue, but we don't know much more about it than that. For diagnosis, CSF is typically normal or just slightly abnormal, and blood tests aren't particularly helpful. You essentially get these dynamic vasoconstrictions as beads on a string on the angiogram that can actually change on repeated angiograms. And all of that is completely self-resolves and normalizes at 3 months. The differential, as you might expect, are other things that might cause vasospasm, arterial changes, aneurysmal subarachnoids, primary angiitis of the CNS, or some sort of dissection. The complications, I'll show some imaging of this. You can get different types of intracranial hemorrhages. You can get press, strokes, and it can be fatal. The management is typically an oral calcium channel blocker, and then basically tell patients not to Valsalva, not to not to engage in sexual activity. But again, it's a short-lived type of thing. We're talking about a few months. Most people recover. Only a few is it fatal. So let's go over some of that detail here. So for kind of the features of RCVS, this was an epidemiologic kind of, I lost my, so this is an epidemiologic, these are 3 different studies that looked at kind of epidemiologic data, and I'm going to kind of summarize it over here on the right. So it tends to peak in your 40s, but there's quite a bit of a range. It seems to be more common in women at about a 1 to 2, 2 to 1 or 1.5 to 1 ratio. We don't know the incidence. We don't know how often this happens. And as you might guess, if you don't catch the vasospasms in that 3-month period, you're not going to be able to make this diagnosis. For headache, the headache is typically thunderclap, and by thunderclap, we mean it goes from 0 to 10 in less than 1 minute. The thunderclap headache typically lasts only a few hours, unlike a subarachnoid hemorrhage. You typically have just about 4 attacks in that kind of 3-month range. And again, it's triggered by a few different things like sex or exertion, or kind of something in that area. But almost everybody, as you can see here, has some sort of thunderclap headache. The natural history, you'll get symptoms, but the symptoms will stabilize after a month and there won't be any new symptoms. The vasoconstriction, again, goes away after about 3 months. You will get, with the vasospasm, some severe deficits in about 5 or 10%, and then a very low fatality rate. Recurrence is possible. We really don't know the recurrence rate, but it seems to be rare. The suggested workup is essentially to look for some sort of sympathomimetic pathway type of thing, so a workup for pheochromocytoma and a UTOX to look for amphetamines or things like that. For diagnosis, the diagnosis is not particularly well put together. It's a little bit still kind of bulky, but there are a couple things that we use. So basically, acute and severe, usually thunderclap headaches, a course where you have symptoms that stop after about a month. You get this beads on a string vasoconstriction on some sort of angiogram, either direct or indirect. No evidence, obviously, of a subarachnoid. Normal or near normal CSF, so you can't have a slight pleocytosis or a little bit of a protein elevation. And then you have normalization of everything at 3 months. There was a score that was developed to try to kind of assess how sensitive and specific, basically what your risk was having RCVS. In this study, they basically took patients with primarily RCVS and primary angiitis of the CNS, but they also looked at a few other things. So here's how the score works. If you have thunderclap headache, either a single one or recurrent, you get 5 points. If you have intracranial carotid artery being affected, you get -2. That was more common in things like intracranial atherosclerosis than it was for thunderclap or for RCVS. If you have some sort of trigger, some sort of vasoconstrictive trigger, you get 3. If you're female, you get 1 point. If you've got the presence of subarachnoid hemorrhage, like a convexity subarachnoid, you'll get 1 point. And then if the score is 5 or more, that was very sensitive and very specific for at least RCVS versus primary angiitis of the CNS. Here are some imaging findings. So this is an angiogram that even I can read. But this is a patient that had 2 weeks of headache and then developed a right hemiparesis encephalopathy. This is obviously a more dramatic case, but it highlights that beads on a string pattern of vasospasm that's typical of RCVS. A few things about the angiogram findings. It can affect both anterior and posterior circulation. It can affect the external carotid artery and the carotid siphon. But again, the intracranial segment of the internal carotid artery is less likely affected than in other conditions. The narrowing that you see here is not fixed. If you get a repeat angiogram in a few days, it may actually show different constrictions. And the angio in the first week of RCVS may be negative, even if there's a hemorrhage or press or something else that you see. You may need a second angiogram. The maximum constriction seems to be about 16 days after clinical onset. And then everything normalizes. You can see this is the same angiogram, but a repeat angiogram, same patient, 4 months later, and all of the angiography, all of the vasospasm has resolved. This is another patient, another case of RCVS showing that you can get both hemorrhagic and ischemic strokes with RCVS, sometimes in the same patient like this one. You can also get press and watershed infarcts with RCVS. So this was a case of a 39-year-old female presented 2 weeks postpartum with seizures and left hemi-body numbness. So kind of putting all that together, the imaging findings, the kind of pathognomonic thing is the angiography with vasospasm, this string of beads type. You can get infarcts, intracranial or parenchymal hemorrhages, press, and convexity subarachnoid. When you're looking at imaging techniques, Conventional angiogram is far and away the gold standard. It's the most sensitive. The indirect CTA, MRA are about 80% sensitive compared to the digital subtraction or the conventional angiogram. Dopplers, transcranial Dopplers, are a little bit less helpful. For management of this, there are no randomized controlled trials. So we're basing everything on expert opinion. So the first thing is to decrease, again, the triggers. You're going to have to do this for a few months, but then it self-resolves. So exercise, Valsalva, sexual activity, and vasoactive drugs. We give you some sort of oral calcium channel blocker or possibly magnesium to relieve the vasospasm as much as possible. There's no data for corticosteroids. They have done biopsies, brain biopsies, and looked post-mortem at patients. There's no evidence that there's inflammation, that there's any kind of actual vasculitis. So we don't use corticosteroids. There's no data, at least, for them. There have been a lot of intra-arterial attempts for these patients. Oops, sorry. So different medications, balloon angioplasty, all these been used with debatable success. I wish I could tell this, in this lecture, in this group of people, that this is the right medication or this is the right intra-arterial treatment to choose, but we just don't have enough data on it at this point. There is a consensus that it should be restricted to patients showing clear clinical progression and not just on everybody. Of note, the fatal cases were refractory to intra-arterial procedures. So intra-arterial procedures may decrease the morbidity, but it's unclear if they actually increase the mortality associated with RCVS. So one last thing I kind of want to posit to this group is, could RCVS actually be a cause of cryptogenic stroke? So this is the International Headache Society's definition of headache that's associated with RCVS. And it's a bit of a choose your own adventure type of thing. We can have one of these or one of those, but I just want to go through it and give you an example of, you could actually go through this pathway. And if you got a CTA, which is only 80% sensitive, and it was negative, you might have had RCVS the whole time. So the definition, the first ones are kind of obvious. You have a headache and you have a diagnosis of RCVS. But the other things that go along with it, evidence of causation by one of these things. So the first one is the kind of obvious. You had a headache, it led you to get an angiogram and you got RCVS. Or you've got some sort of feature of the headache, whether it's thunderclap or triggered by something like sex or exertion, or it's present for less than a month and then it doesn't change after a month. And then the headache resolves within 3 months, or you're not yet at 3 months, but it will likely resolve in 3 months. So again, this is a choose your own adventure type of thing, but according to one of the pathways, you could have any headache that's present for a month and then goes away, and it could be RCVS if you didn't get the imaging. So again, a patient could theoretically have a stroke with a 2-week history of headaches and have a negative CTA, which again we know is only 80% sensitive in RCVS, and the cause of the cryptogenic stroke was actually vasospasm due to RCVS. So that doesn't mean we should be doing conventional angiograms on everybody, but this would be my takeaway point for RCVS for this group. There's typically no vasospasm the first week that RCVS starts. So if you have an otherwise healthy patient that complains of new headaches and then 2 weeks later has stroke, then I think RCVS is a reasonable consideration. And if the CTA is negative, you could consider doing a conventional angiogram to rule out RCVS. If you find a patient has a stroke due to RCVS, that will change your long-term management perhaps quite a bit, because that's just a different conversation you're having about aspirin, lipid management, blood pressure control, and those types of things. So I just kind of want to posit to that we don't know the prevalence of this or the incidence of it. And it's something that's kind of fleeting and hard to diagnose. And the testing we have outside of conventional angiograms isn't perfect. So let me kind of move on for the last part to talking about the new migraine medications. And again, I think all of these have vascular effects and are something that you guys are going to have to ask about just because of how common migraine is. I know a lot of people did not go into headache medicine here, so I'm not going to go over everything. But I think there's some things that are important to mention. So one thing for the trainees here, Before I talk about the medicines, I do need to remind the audience that migraine aura can look indistinguishable from a TIA. So here's a video that shows a reporter having a migraine aura live on television.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go to Terrace and look for the head of the pit.
As a fun fact, the day that video came out was the day that Google saw the most searches for migraine. Still hasn't been beaten, but that was a migraine aura. The patient has expressive aphasia along with her migraines. So the definition of a migraine aura, this is found in about a third of patients with migraine, is that you have at least two auras. They're fully reversible, and there's some sort of kind of neurologic feature. Vast majority are visual, it's 90% of them. They can be sensory, kind of numbness, paresthesias, speech or language like that patient, the aphasias. You can get motor, so there is hemiplegic migraine or brainstem like vertigo. There's this odd retinal one where it's essentially visual but monocular only. And then it has some sort of characteristic down here that it spreads gradually, or you get two of them in succession. You might get vision and then speech changes. They only last an hour or less. At least one of them is unilateral or positive. Positive being that you see something new, you're hallucinating something as opposed to just getting blurry vision. And then it's accompanied or followed within an hour by the headache. So that was kind of a dramatic case. Here's a more typical kind of visual aura. So this is kind of an artist's rendition, and it's been sped up quite a bit, obviously, because this goes on for 20 to 60 minutes typically. But this is a visual aura, what a lot of patients will describe. This one will not be concerned as much with, or mixed as much with a stroke. But it's hard to explain. It's hard for these patients to explain what they're seeing, but they'll often have some sort of central scotoma. They'll see either what they call either zigzag lines or a kaleidoscope kind of crescent shape towards the edge. These are fortification spectra, sometimes what we term, and then it will slowly expand and move over the course of about 5 minutes to an hour, and then kind of fade out like this, and then be followed by the headache. But that is kind of the most common aura that you might see. But again, some of them can look exactly like a TIA. Patients have gotten, obviously, TPA for migraine aura. Here's our theory of how it works. It's something called cortical spreading depression, this wave of electrical activity that kind of starts from the back of the head in the visual cortex and then moves forward. So I was going to show this video here.
Cortical spreading depression. What's behind the aura? As neurons begin to fire, starting with just a few, the unstable activity continues throughout the brain, causing the vision impairment, which is the aura.
So basically what she's trying to show on here is that you get electrical activity. It's not epileptogenic. These patients don't get seizures or anything like that with these, except for on very rare occasions. But you can see how most of them are going to be visual auras. So it starts in the back, and you can also see why you might get auras in succession. So you just get visual first. As it moves up to somatosensory cortex, you're going to get tactile things. As it moves up to motor or Broca's area, you might get motor symptoms or an aphasia. There's actually a cool device now that's a magnet, a transcranial magnet, that when you start to get the aura, you put it on the back of your head over the visual cortex, activate it, and it breaks this electrical activity and stops the aura, and then you don't get the headache. Now, it does also work for patients who have migraine without aura, so we're not quite sure how it's working, but the theory was a very neat kind of idea. So these are I'm going to very quickly review our current migraine medications so you have an idea of the current landscape, and then we'll discuss the new ones. So these are the recommendations from American Canadian guidelines. These are the as-needed medicines. As you can see from migraine, we really don't have that many options. So there's acetaminophen, there's different NSAIDs. Sometimes one is more helpful than the other, but they're all NSAIDs. And then there are the triptans. Ergots are essentially an older generation version of triptans. And then we have combinations essentially of these ones up here. There are thoughts that, sometimes one of the triptans works better than the other. They definitely, some of them have less side effects than the other. But 3 of the new as needed medications are not in any of these categories. On the preventive side, these are medications that we do have a lot in a lot of different categories. But as you can kind of look at this list of medicines, a lot of these, or possibly all of these, have side effects that are not trivial. So you're looking at blood pressure medicines, topiramate, kind of old school tricyclic antidepressants. Kind of as you go down the list, these all have issues. In some patients, they're going to have contraindications. And the side effects have really been the problem with a lot of these. Hence the development of the new CGRP antibodies, the one here at the bottom, Reversible, being one of them, that have a lot less side effects than the other medications we have here. So I'm just going to briefly go through the different medications. I'll just show you that all of them have done their homework and have done their 2 randomized controlled trials. For migraine now, the FDA has requested that all as-needed medications have the same 2 primary endpoints, so pain freedom at 2 hours and freedom from your most bothersome symptom at 2 hours. That means they asked you what bothers you the most, your light sensitive, your noise sensitivity, or your nausea. And then at 2 hours, all right, is your nausea gone at 2 hours, or whichever one bothers you most, is that gone at 2 hours? So this was lasmiditan. Lasmiditan is essentially a triptan that does not cause vasoconstriction, and I'll show more about that in a second. But they met their primary endpoints with their 2 studies. A quick thing about the adverse effects, they're similar, I suppose, to the triptans, but there is a requirement that you don't drive for 8 hours afterwards, and they were found to be slightly addictive. So there is this kind of Schedule 5, kind of like pregabalin is. Ubrogepant is a CGRP blocker, but this is a pill. It is not an antibody. It is only short-lived, and it's an as-needed medication. So the primary outcomes, again, were the same as in the other study, and they met their primary outcomes for pain freedom and freedom from your most bothersome symptom in both of their clinical trials. The adverse events for this one, kind of mild things, but somnolence, nausea, dry mouth. There was no hepatotoxicity in this. These types of medications were actually developed decades ago, but all the ones that were developed decades ago caused hepatotoxicity. So they now have these kind of newer generation ones that do not cause hepatotoxicity, but they make a point to point that out. And then rimegepant, so the other one was ubrogepant. This one is rimegepant. Again, it's a CGRP blocker in pill form that's used as needed. They also met their primary endpoints. Adverse effects, nausea, UTI, and again, no hepatotoxicity in either group. And then there are all of the different CGRP antibodies. And I know I'm not supposed to use the brand names, but I'm going to mention them just once for each of these medicines so you know what we're looking at. But fremanezumab is Ajovy. Eptinezumab, which just came out last month, is Vyepti. Galcanezumab is Emgality, and Reversible is Aimovig. All of these have come out in the last 2 years. Reversible first, Galcanezumab and fremanezumab a few months, I think about 4 or 6 months later, and then eptinezumab last month. The first 3 are antibodies to the peptide itself. The last one, Reversible, is a peptide to the receptor instead of, but either way, the idea is that the CGRP does not bind to its receptor. And I'm not going to go over all the clinical trials, but they did meet all their primary endpoints. For endpoints, the preventive medications is how many less days of headache per month do you have? If you're curious about how effective these new medications are in comparison to our old ones, an institute tried to do that. So they took the clinical trials and subtracted the placebo group from the experimental group. So if for example, the placebo group had 2 less headache days per month, and the experimental group had 3 less headache days per month, that's 3 minus 2, or 1 less headache day. Hopefully that makes sense. Basically, they're trying to account for the fact that some of the placebo patients also improve, and that's variable across studies. So here are our old kind of tried and true medications for episodic migraine. You get about 1 or so less days of headache per month on average, which is I admittedly not great, but these are the best headache medications we have. The new ones are kind of in that category, in that ballpark, but maybe slightly better. This is for episodic. If you look at chronic migraine, you get a little bit more reduction in headaches per month. If you look at the onabotulinum or these other ones, you get maybe a little bit slightly more benefit. But these haven't really, there's not a big difference, I guess I would say, in the effectiveness. What we've seen clinically is that there's a big difference in side effects. There are just simply not many side effects with the CGRP blockers. So these have really exploded in clinical practice. I think partly it's the marketing. I'm just being cynical, but just being honest about it. They're doing a very good job of marketing. But largely, I think it's because the effects are so low. The side effects are so low. So again, I don't have any money with any of these companies, but it's just weird from my side of things as a headache physician to ask a patient any side effects with the new preventive medication, and they come back and say, no, not really. Seems to be working okay, and I don't really notice anything. It's a new thing for us. It's just a very odd kind of phenomenon. So they really have a lot less side effects than you might expect with a topiramate or something else like that. But here's kind of the issue with them from a vascular perspective. So here's what the slide explaining vascular issues. The tried and true kind of first line as needed for migraine is the triptans. The triptans work on serotonin agonists. So as serotonin agonists, so they work on the 5-HT1D, 5-HT1F, and 5-HT1B receptors. 1D and 1F end up blocking release of pain signaling molecules like CGRP, neurokinin A, and substance P. But by activating the 5-HT1B, they cause vasoconstriction. And these are why we typically don't want patients who have had strokes, who have had myocardial infarctions to take the triptans. The CGRP, and I kind of just had to draw this in here, we don't really know where it works. It doesn't get through the blood-brain barrier very much at all, which is just an interesting kind of phenomenon. It's just very low in the CNS. So we're not sure where they work. But wherever they do work, we think they're blocking CGRP, and by doing that, they're directly reducing nociception. However, CGRP, and I'll show this in a second, is a very potent vasodilator. So you're also blocking vasodilation. You're not constricting the blood vessels, but you're blocking dilation. So let me show a little bit more of that. But just to kind of go over it first, the triptans are 1B and 1D, so they do constrict blood vessels. Lasmiditan, the first medication I showed you, is 1F receptor agonist only. So it works on this part of the pathway, but it does not cause the vasoconstriction side. All of the other ones are some sort of CGRP or CGRP receptor blocker. So they end up reducing nociception, but also blocking vasodilation. So let me kind of show what we know about these CGRP antibodies. So this was a study where they took human arteries during neurosurgical procedures. So they removed them during operations for tumors, and then they took them and studied them ex vivo. So these are human cerebral arteries. For this study here, if you're looking at CGRP, this is increasing concentration of CGRP. On the y-axis here, basically kind of going down the y-axis, is more dilatation. So if you give a cerebral artery CGRP, just give it the peptide, you'll get this nice dilatation of the artery. If you give it this one, which is fremanezumab, you'll get much less dilatation. And if you give a higher dose of fremanezumab, you actually get no dilatation at all. KLH, this was basically a control antibody, and you get some vasodilation a little bit more than the fremanezumab. Of note, it's not just the cerebral arteries that it affects. They also looked at the middle meningeal artery, abdominal arteries, same thing, where it actually also decreases the vasodilatation. So we know that these block the ability of human cerebral arteries to dilate. Functions of CGRP, this is what you're blocking. So CGRP is a potent vasodilator, more potent than histamine, prostaglandin, substance P. It also may promote angiogenesis in response to ischemia. So again, you're blocking these functions. Cardiovascularly, it does cause vasodilatation. It has positive ionotropic effects and chronotropic effects, but it doesn't seem to affect blood pressure at all. So there have been some case reports. Again, it's always hard to know what to make of case reports, but there have been case reports concerned with vascular phenomena. So ischemic stroke in one patient soon after he took a CGRP inhibitor. There were a couple of patients who developed new Raynaud's phenomenon after taking the CGRP antibodies. So there are concerns, at least initially here, that there might be some issues. One of the companies actually tried to investigate the cardiovascular side effects of their medicines in patients with stable angina. These are some very brave study participants, in my opinion, to basically take a medication to see if it would make their angina worse. But they essentially designed this study like a clinical trial. Participants got 2 baseline treadmill tests, and all of these had chronic stable angina. And then they were given either placebo or one of the CGRP antibodies, Erenumab. And then they did another treadmill test the same day to see if the treadmill test would actually see if the medicine would also actually make the angina worse. And then they also followed them for 12 weeks for safety. Their primary endpoint was the change in total exercise time, and there was no significant difference between the two groups, suggesting that Erenumab did not affect stable angina. Their secondary endpoints, the time to angina, how long it took you on the exercise to get your chest pain, was no difference. There's no significant difference. The time to onset of 1 millimeter ST depressions on the EKG was also not significantly different between the two groups. So this study has been obviously criticized, as they all are, for a few different reasons. And we don't know if it's generalizable to other things like myocardial infarction or stroke, but I do commend them for at least making an attempt to characterize the effects in a patient population that's been at risk. But this is kind of all we know. We have case reports and we have this one study, and then we have basically the basic science data that shows that it's an issue with constricting or preventing dilation. So kind of just my opinions on how we should proceed with the CGRP inhibitors and vascular issues. And this is just my last slide to kind of leave with everybody. But the one option would be kind of the more stringent option, which recommend them just like you'd recommend a triptan, like you'd recommend sumatriptan, and don't use them for any neurovascular or cardiovascular issues that you wouldn't use a triptan for. Maybe even don't use them for a disturbed blood-brain barrier, because if you've just had a hemorrhagic stroke or something, these typically don't get through the blood-brain barrier, so we don't really know what happens if more got through. But we'll just wait for more clinical data before we kind of prescribe them more often. That would be the more stringent way of doing it. The kind of less stringent would be kind of just case specific. Don't use them in specific situations where dilation is essential. So that would be something like a stroke with penumbra, vasospasm, active vasospasm, something like that. But in other situations, counsel patients about the risks and benefits and make a shared decision. The contraindications for these medicines do not formally include that you have to keep them if patients had a stroke or anything like that. So there's not a lot of guidance on kind of what we do. And a lot of this is going to be talking with the patient just about, can I start a medicine or should I stop a medicine? One thing I'll note for the CGRP antibodies is the half-life of those medicines is about 30 days. So, if it takes 5 half-lives to get out of your system, it's going to be about 5 months to get out. And there's nothing we know right now to reverse it or get it out. But that's kind of what we're left with. So sometimes it's a question of when do you start medicines or something else. And then finally, the lasmiditan presumably is safe. Now it's only brand new on the market. It came out in February of this year, so just 2 months. But as far as mechanistically, we don't think it has any vascular effects. Should be fine to take, irregardless of what your vascular issues are. So I know that was a few different things that I reviewed. I just want to kind of make sure I address things that this this audience would find interesting and not just talk about migraine the whole time. But thank you guys for your attention, for having me being part of this this study break, or this SVIM break.
Thank you, Mark, for that wonderful talk. Before we go to the question and answer session, I wanted to remind everyone that if you enjoyed this webinar, this is an opportunity for you to consider joining SVIN as a member if you are not already. Also, to remind everyone of our 13th annual SVIN meeting, that will be November 18th to 21st at the Westin in LA, California. And if you're looking for other opportunities for continuing education, I recommend the online educational courses called BSES and ASES for EMS. So one of our questions that we received that I will go to is, if you have a patient who has CVST and dissection, often they have bad headaches, but sometimes they'll need full anticoagulation. What acute treatment options are available other than Tylenol for stroke patients that are on full anticoagulation?
Yeah, good question. I think if you're looking for basically acute treatments, if you're looking, like I talked about before, you've got acetaminophen, you've got the triptans, which you really can't use in that situation. You've got NSAIDs, which you really can't use in that situation. Theoretically, this new lasmiditan medication would be okay. There's not a lot of data for this, but some of us will use some of the muscle relaxant tizanidine, for example, to try to kind of block a headache, or a low dose of gabapentin, just 300 milligrams of gabapentin. I like occipital nerve blocks, but again, trying to do that when you're on some sort of blood thinner is probably not ideal. So in those situations, maybe this new lasmiditan and maybe a muscle relaxant or gabapentin. And then you probably can't do this as an inpatient, but there are a lot of neuromodulation strategies now. There's a device that goes on the forehead. There's a device that goes on the neck. There's a few different types of things that really don't have any issue with hypercoagulability.
Okay, excellent. Another question we had is, what is the safest, or what's the safety for doing Botox and nerve blocks in patients on full anticoagulation?
I don't know. I mean, that's kind of the short answer with that. So it was Botox, and what was the nerve blocks in general? Yes. Yeah. So I personally don't do them, but I know a lot of physicians who do Botox and things. Theoretically, you're just putting it into the superficial muscle layers. So you would think of maybe some small hematomas in those areas would be typically a minimal kind of issue. But I personally don't do them. I haven't seen a lot of data one way or the other.
Okay. Our next question, have you seen patients with RCVS and have their extracranial vessels affected as well, like the vertebral artery and ICA cervical segments?
I personally haven't, but I haven't seen that many RCVS cases, unfortunately. So theoretically it's possible, but again, we know so little about RCVS kind of as far as epidemiologic and just even fully described that I'm not, I don't know.
I'd have to say in those patients that I've treated with RCVS, I haven't seen cervical segments as well. I might think of a vasculitic process if I saw that. How long do we treat with nimodipine in RCVS?
Typically, we know it goes for 3 months. It is typically the duration. So I would do something like around 3 months to 4 months, and then stop the medication. So for that patient that I talked to, that Sunil Sheth was helping me with, we put her on a calcium channel blocker for 3 months, and I called her. She said she had no more symptoms. We stopped it. I called her again in 3 months, still no symptoms, and then I haven't heard from her again.
Okay. If someone is complaining of headaches in acute stroke due to RCVS, would you still start a calcium channel blocker or carry on with permissive hypertension?
That's a great question. I don't know. My guess it would be the same type of thing that you do for subarachnoid hemorrhage, which is you may need to do some sort of intra-arterial kind of issue if you think you've got something you can take care of locally. But I don't know the answer to that. I don't know if you have thoughts, Robin. I'm sorry to turn this back on you as the moderator, but I don't think there's any data on what you should do. So my guess is that the stroke takes precedence. I don't think we know anything about if the stroke would, if increased blood pressure would actually cause more vasospasm or not.
So it is a very good question, and I think a difficult dilemma. So if you think about the etiology of strokes in patients, it's probably from a lack of perfusion to a territory with severe spasm. I think in those particular cases, that's when I might be pushing some intra-arterial process like intra-arterial vasodilator or balloon angioplasty. But it is a very good question. Another question that we had, which patient should go on oral calcium channel blockers following RCVS diagnosis? What would be your choice of medication, dosing, and duration?
So I think all patients, unless there's a contraindication, should probably be on calcium channel blockers after when they have a diagnosis of RCVS. As far as which one, I don't think we know. I think the ones that I had mentioned, nimodipine and verapamil, but the dose is kind of unclear. I don't think they necessarily need to be titrated to their blood pressure, until they're symptomatic or anything like that. Probably on the lowish side for that one patient, at least that I had, I'd put her on a lowish side of verapamil. But yeah, I think there's unfortunately no data about it.
Okay. Is the stroke risk only increased in patients with migraine with aura?
Primarily with migraine with aura, yes. I think stroke is technically an independent risk factor for, migraine is an independent risk factor for stroke, but primarily it's the aura part. The biggest risk seems to be patients on migraine with aura who take oral contraceptive pills and who are young and smokers. It's just an odd combination of things, but that seems to be the group that's at the highest risk. And we're not talking about a huge dramatic increase in risk, but that seems to be the group that's the highest risk. There were studies that looked at PFOs to see if closing the PFOs would make a difference for migraine with aura and stroke risk. That study was negative, but that seems to be the highest group.
Okay. Would the treatment approach be similar in patients with moyamoya, as they can present similarly as RCVS with headaches?
I don't know. That unfortunately, that's about as far as I can go on that one.
Okay. What is the best migraine treatment with pregnancy?
Good question. So we have a list of medicines you can use during pregnancy and medications you can use during breastfeeding. So for pregnancy medications on the as needed side, the best ones are Tylenol, oxycodone. Of all the opioids, oxycodone seems to be the safest. We do not like opioids, except we'll use them in pregnancy, and occipital nerve blocks with only lidocaine. Those are kind of the as needed that we typically use. On the preventive side, the ones that we typically use, there's one beta blocker called Pindol. I believe it's Pindolol, which is seems to be a little bit safer than some of the other beta blockers. Memantine, which is the Alzheimer's medication, has some data for migraine, seems to be very safe. Riboflavin and magnesium at high doses seem to be okay. And then all of these neuromodulation devices, although we don't have a lot of data for them, theoretically, they would all be safe because they're more of just a local kind of stimulus, usually electronic stimulation. The CGRP antibodies we know nothing about, and we do counsel the women, if you think you're getting pregnant, you do need to stop these for 5 or 6 months to get off them completely.
Excellent. Does CGRP alter the effects of nitroglycerin?
It's a good question. I don't think I'll have to go back and see, but I'm not sure that's been studied to know if they block the effect. I will say in patients who are on hydralazine, who have very hard to control blood pressures, they're on multiple different agents and are on hydralazine, I do not give CGRP just because I'm worried about that vasodilation issue.
Okay. Someone has asked this question. I have to say I have experienced this in several patients where we have large cavernous aneurysms or large aneurysms that we stent, and they will develop headaches in the acute period after treatment, which we presume is maybe from inflammation from the thrombosing aneurysm. And the question is, some patients, especially young women, after treating their intracranial aneurysm with stent, develop headache and vasospasm in the follow-up angiogram. How would you approach these headaches? Calcium channel blockers, beta blockers?
Yeah, so good question. On the side of it, as far as mechanistically, for headaches, the way we think even migraines work is that the brain itself is insensate, right? You can do deep brain stimulation, the patients aren't screaming. The things that are really sensitive are the dura and the large intracranial blood vessels. So placing a stent, stretching an artery or kind of pushing on the artery like a carotid dissection can be quite painful. So that part, I understand mechanistically it makes sense. Why it affects young women more than others, that I don't think we know why. The vasospasm part, I'm not sure. I mean, we know that vasospasm can happen with carotid dissections. I mentioned that a little bit, that it can go along with our CVS. So maybe there's a kind of a mechanistic link there. Treatment-wise, I think the general, I don't think there's any, for carotid dissections, I don't think there's a medication that we have decided this is the medicine that's going to help pain associated with carotid dissection. The general teaching in headache is you treat the phenotype, whatever the headache kind of looks like, you treat that. And that's, usually is what we see with that is TBIs and concussions. When they get headaches afterwards, they may look like tension headaches. They might look like migraines. You treat them whatever they look like. So for those patients, you essentially ask them, what kind of pain is this? If it has kind of a migraine flavor to it, you try those medicines. If it has more of a neuropathic pain, I get this, it's just this burning pain right where on this side, you'd probably try the neuropathic medicines.
Okay. One additional question: for patients with refractory migraines who are relatively well controlled on CGRP and wanting to get pregnant, what alternative therapies do you recommend, and is Botox safe?
I'll start with the Botox first. We don't know with the Botox. I've heard differing opinions on that. I've heard everything from, the Botox half-life is actually very short. It's just the kind of effects of it are long lasting, so it's okay to do. I've seen people do it during pregnancy, but we don't quite know. Most people will tell you to stop Botox for 3 months because it takes 3 months for the Botox to wear off as far as the effects go. But we don't know. I don't think, if I remember right, that it really gets in and would cross too much into the blood, into the kind of placental maternal part after a short period of time, just because it doesn't get into the bloodstream and stay there. As far as what options you would use instead, or what you would kind of counsel patients to switch to, there's not a lot of data on, if the CGRPs work, then these other medicines will also work. So unfortunately, the CGRP doesn't give us much guidance on what you should try instead. Theoretically, you would want something either with a very short half-life so you can get off of it quickly if you're kind of trying to get pregnant, or you would want something that just has a low risk, the kind of the things that one of the other people had asked about during pregnancy, like memantine or Pindolol or riboflavin or a device.
Okay. I think we have time for one more quick question. What are your thoughts on PFO closure for potential migraine reduction?
Yeah, so the study was negative, and that it didn't really make a difference. I have to go back and look, though. I forget if the study actually looked at the headache frequency reduction, or if it was more in kind of stroke types of things. But I have seen patients who have these aura. I had a patient who was having TIAs, and we closed the PFO and the migraines got better. But right now, as far as the headache community goes, it is not recommended. So it's a good question. I think it's still an open question. I've talked to, there's a couple of people on the headache side of things that are kind of unconvinced from the first study that is the final nail in the coffin on this. So I think it's kind of ongoing. There's this weird relationship between headache and vascular things that for decades, since the early 1900s, we thought migraine was a vascular disease. And then later we said it has nothing to do with the vasculature. It's all because CGRP is elevated, and CGRP dilates blood vessels. It's a completely indirect thing. And now we're coming back to saying, well, genetically, all these susceptibility markers, literally half of them are vascular genes. So I think there are a lot of kind of stones that need to be unturned for that. And I don't think we have an absolute answer yet.
All right, wonderful. Thank you so much, Mark, for your talk. This is a great topic. There were many people that were thanking you in the Q&A questions for your talk. They thought it was a very good one. I want to thank our industry supporters for making this webinar possible. And I want to thank everyone who was able to join us this week. And please take a few minutes to fill out the survey that will automatically come up after the webinar closes. It will also be emailed out to participants in the coming days. And a reminder to claim your CME. You want to log in to the Spin Break portal where you enter the meeting and click Claim CME Credit to claim your CME. If you registered late, please allow 1 to 2 business days for your name to show up in the CME portal. Thank you to Mark and all of our speakers.